Resistance is the problem. So really, except in rare circumstances, most patients will meet a endocrine therapy resistance wall in their treatment any time between the first few months on therapy when it doesn't work at all, right through to a progression event that could be 3 or 4 or even 5 years down the line. So when we think about resistance, we do think about it in two broad phases: intrinsic resistance to endocrine therapy and then these acquired resistance problems. We've actually been studying the molecular biology of acquired resistance to endocrine therapy for some time, and it's been clear that recoding events within the estrogen receptor gene itself are a cause of acquired resistance, and perhaps as many as 30 or 40% of patients, when they become resistant to aromatase inhibitors and tamoxifen, will have mutations in the estrogen receptor that cause ligand-independent activity. We've recently also discovered another recoding event in the estrogen receptor involving estrogen receptor translocations, which are really interesting because when those events occur, all endocrine therapies are off the table because there's no drug binding domain. It's replaced with a chunk of coding sequence from another gene. Interestingly, in experimental systems and in patients, those patients who have estrogen receptor mutations or fusions can actually respond to CDK4/6 inhibitors because these drugs block the cell cycle downstream of the estrogen receptor. So even if the estrogen receptor is constitutive or translocated, CDK4/6 inhibitors can still block proliferation.